Welcome to Stablish, where EMS lives somewhere between stable and ish. I'm Josh Kingston, paramedic, educator, and your host. This podcast is for crews who work the chaos, manage the maybes, and make the call when protocol meets real life. The name Stablish comes from a familiar EMS dilemma: the patient who isn't crashing, but isn't stable either. They're not critical enough to demand aggressive intervention, but they're not the kind that you just walk away from. They're Stablish, this gray zone where decisions get nuanced, teamwork matters, and judgment meets protocol. Welcome back. We are here for the Stablish episode of the podcast. We are going to talk to Dr. Lewis and discuss protocol changes, and which should be soon coming out, hopefully. So we're going to go through some of those changes and just kind of talk about them and why we think we need to update them. Okay? Just to dive into it. So what are some of those major themes that you kind of went through to make those protocol changes?
I don't know that there was specifically a theme. I think it was all provider driven. I mean, these are all protocols that have been brought about by our providers that really wanted to see a change in some of our protocols. And so I would love to take credit on any and all of this, but I can't take credit on any of it. This is our provider driven, pushing us to, hey, why are we doing it this way? Hey, there's new science, or I've seen new science. What do you think about this? And some of the recommendations were great. Some of them just didn't have any science to back them up. There's plenty of TikTok pushing us to do something different, but we're super excited about this being driven from our providers.
All right. So I think we can probably kind of break it down into some categories. Like there's some cardiac arrest and resuscitation changes, right? And then we've got some sepsis and shock updates and airway and respiratory, and we've even got some pediatrics. So let's dive right into the cardiac arrest ones. We've got several changes, along with the 6 milligram max epi. So what is that?
Well, I'm pretty excited about that. It comes from a location of, we started to see more and more cardiac arrest resuscitations where 12, 15 milligrams of epinephrine were given over an hour. And I think you could force somebody that's been buried in underground for a year to get their heart to beat a little bit with 12 milligrams of epinephrine.
Probably.
So this really kind of stirred from that. So we started to look at science. Where is it that this makes a difference, or do people survive from this? And there really wasn't a ton of science about, do people survive after 1 milligram, 3 milligrams, 12 milligrams? There were a couple really small studies that showed that nobody left the hospital after 6 milligrams. Actually, it was after 5. We just erred on the side of caution just because the power wasn't great. And so we were trying to cover this. But realistically, we know that person that got 12 milligrams of epinephrine, that's just going to create you to have to transport that patient.
Right.
And so we were pretty excited about at least giving you a protocol that limits how many. Now, it doesn't mean that you can't start an epinephrine or you give them push dose epinephrine, because we don't want to miss that person that's hypotensive.
Right.
That still needs some epinephrine just to raise their blood pressure, get that peripheral vascular resistance up so that we can now feel their blood pressure. And without us having ultrasounds to ultrasound their heart to know whether they're having good squeeze or not, it gave us a chance to go, hey, we've pushed this to the max of what is reasonable for somebody to go home.
All right. What about bicarb? Taking that out.
Yeah, so bicarb should have been out a long time ago. I mean,
right.
The science really pushed that if you change somebody's acidosis in the bicarb, you definitely will potentially get a heartbeat back, but none of those people went home. And so it did make us feel better on scene, but then it also made us transport a lot of patients that were never going to go home, that were not going to survive. And so the bicarb is there for still in cases.
Right.
So we still see it for those that, if you think they have hyper K, we want to be using bicarb. But that long downtime, we assume they're acidotic. There are protective mechanisms there. Our body goes into a different system, right? All of this survival mode when we're acidotic. If we're just taking that away, yes, we'll get a heartbeat back, but you're not going to help that person survive.
Right.
So just wanted to take it out of there to give us, hey, quit giving the bicarb to people that have just had a long downtime.
Yeah. So I know you talked about a lot of like evidence and studies and stuff like that. What is that really? What is driving all of these? Are those studies and those research based evidence?
Definitely, it is how we make these decisions. Probably on a week to every other week, a provider says, "Hey, why aren't we doing this?" And that really kind of falls into those studies. And not just any study was published that said this was right, because anybody can do some published study and get it published in some journal that says, hey, this helps people, when it really doesn't. We've given lots of medicines over the year to people that we've realized doesn't, and that's where it came from. We really dug through the literature to make sure these changes are the cutting edge of science, and they are very likely to help and not harm anybody.
All right. So one of the things that I did notice was that we removed the requirement for the 20-minute PEA for termination. So what should we be thinking about now that we've taken that out, and why did we take that out?
I think the 20 minutes is still a nice benchmark to keep in your brain, but at the same time, there are people that have a PEA that have a rate of 10. You're getting an ectopic beat about once every 10 or 12 seconds. There's a difference between that PEA and somebody that has an organized rhythm at 40 or 50. We've got to work those codes better. And I feel like we were handcuffed a little bit by the difference. And when we leave it in there, it's like, hey, the 20-minute mark is the mark that we should be calling for PEA. That's not necessarily the case. We should be calling to terminate a resuscitation when somebody has really no organized rhythm. That 5 or 10, we get these escape beats every once in a while because we gave some epi.
Right.
That 20-minute mark isn't the mark that we were like, hey, I'm going to call this because there's still a rate of 55, but I can't feel a pulse. It's 20 minutes. I'm just going to go ahead and call this. That's not the right time to call that either. That needs to be pushed further. Okay. So I think we were giving people this arbitrary number of 20 minutes just to make you work a code a lot longer on the scene, or when we should have worked it longer, this escape of, it's been 20 minutes now, it's still at 55, we're just going to call it. So we want them making good clinical decisions, not watching a clock.
Yeah. All right. Well, let's move on. Let's talk about sepsis, because this is another one that I'm excited about. We've got Rocephin.
Yeah, so I'm super excited about this, and this has been a long time coming. We've wanted to do this for a long time, and there's a chance that we may isolate down to just one antibiotic. Ancef and Rocephin have a lot of cross coverage. For us to carry both, we may just stay with Rocephin as our main one because it does a good job for sepsis. But the reason why we've been slow about this is for a long time, in-hospital infectious disease really pushed us and said, no, we have to get blood cultures before we start antibiotics. But that's all changed.
Right.
So now JCO and the hospital organizations now say if that person is sick enough that they need antibiotics right away, we don't care whether you get blood cultures before or not. And so what that does is it opens up the door for us. It opens up the door for us, well, if we can pick the really sick patients, that it doesn't matter whether we get blood cultures first or not, then that seems like that's the patient we should be treating.
Right. So when should we start that Rocephin? Like as soon as I come up on scene and I'm like, oh yeah, this is definitely sepsis. Start an IV and hook up that Rocephin as soon as possible, or go through like a SOFA checklist before I do any of that?
Well, definitely Rocephin is an important part of people's survival. We know antibiotics is how people leave the hospital intact, get to go home, spend more time with their family, and don't die of sepsis. But two things. One, they need to meet a criteria of these are the sick of the sick sepsis that we can start without the blood culture. So this is somebody that you know has an infectious illness and they're hypotensive.
Okay.
So when they're hypotensive, then the flag goes up, hey, maybe I can start Rocephin on this person. But we also need to understand that Rocephin is not the needle decompression of sepsis, right? It is for trauma. Like, I'm going to do this, and wow, I just saved their life. It is important for their survival that they get it early, but there's so many other things that are important. Still, our ABCs are what's going to save that person in the next few seconds. We have this conversation a lot, you and I, about what's going to kill them right now and what's going to kill them soon. And sepsis is going to kill that person soon. What's going to kill that person right now? If they're not ventilating well, because if they're super hypotensive and not perfusing their brain, that's going to kill them right now. So we still need to be addressing kill me now stuff.
Right. So should I be given fluids before I give that Rocephin?
Yes.
Yeah.
So if they're hypotensive, we need to be trying to bring their blood pressure up first, right? The Rocephin is not going to fix that low blood pressure for hours and hours.
Right.
So kill me now. That's going to kill me now, my hypotension. And so we need to be starting fluids, dumping fluid, knowing that that's running, making sure their airway, making sure they're well oxygenated.
Maybe some push-dose pressor.
Yes, push-dose pressors. All those things to get them more stable,
and
then we go to the Rocephin.
Down the road, get the Rocephin
Yes,
down.
absolutely.
Yeah.
And we are going to save lives with it. You're going to get that Rocephin on earlier. And the reason we chose Rocephin versus others is double dosing of Rocephin is not as caustic on our kidneys. Some of the other antibiotics that are given, Maxipine or Cefepime and some of those, if you give it and then somebody in the hospital gives it in a short order, that can be pretty hard on our kidneys. Rocephin gives us a lot more comfort of, it's a great medicine. I use it for sepsis all the time in the hospital or in the ER. But yet we also don't have to worry about that double dose if somebody didn't get the good information from you and dosed them again with Rocephin 2 hours later, 4 hours later.
Yeah.
It's not going to kill their kidneys, likely.
All right. So on top of that Rocephin that we've added, you've also put into the protocols now the Capno and the end title. So what are you kind of hoping to get from that? Like, is that a number that we should be looking for as well? Because I know, what is it, 22, 23? If they've got an end title, that's kind of like their lactic acid equal. So, and we've been teaching that for a while. We just now put it in the protocol, right? As written down, right?
Yeah, and I think capnography is just one of our tools, right? It would be if I made you only listen to the patient, but not see them, not get a blood pressure on them, not get a heart rate on them. I feel like that's where capnography is a huge clinical tool that we have access to. We can do on every patient we have a concern for. It just gives us one more clue. And if they're at that 22, you're like, oh man, there is a reason they are breathing that fast to get their capnography that low. Why is it? Are they hyperventilating because they're anxious? Are they super acidotic because they're septic? And those are usually two different patients, right?
Yeah, so is that something that we, like, sepsis is something that we're getting better on recognizing in the field. We're still not great, but we're getting better. So that end title can really help diagnose and get that one more tool that you were saying.
Cheat code.
Yeah.
It's a cheat code. I have those same cheat codes in labs and x-ray. I get extra cheat codes. You have this cheat code in the field. And it helps you. You're like, aha. That gives us that extra information.
All right. Well, Moving from end title, let's talk about airway stuff. So, Decadron. Decadron, you're bringing that back?
Right. So Decadron is a highly debated drug for us.
Yep.
And the biggest problem was because we were double dosing steroids. We were oftentimes giving Decadron, sometimes nebulized, and then we were given Solumedrol IV. This is one of the things that we found that we potentially were causing harm to patients. Adrenal suppression is real, particularly with high doses of steroids. And then when we started double dosing, that's why Decadron came off. We're super excited to have it back just as an extra alternative. Decadron can be used in so many ways that Solumedrol is more difficult to use. But we've talked about this often about why we love Solumedrol over Decadron. Decadron has a half-life that lasts days. Solumedrol has a half-life that lasts about a day.
Yeah.
And if I make the wrong decision in a septic patient that I thought maybe was more COPD, and I use Decadron, me in the ER, me as the hospitalist, the ICU doc, we have to pay with it. We have to pay for that error in our judgment for 3 days with Decadron. So why we love Solumedrol so much that we can dose it, and then if they need it again in 18 hours, 24 hours, we can dose it again. Whereas Decadron is on board. And I think it's been long enough that we are coming with good education about this is why we don't double dose steroids. We don't give Decadron and Solumedrol. So I think we're ready for it. Our providers are ready for it to have it back.
So are we bringing it back for pediatrics only, for adults, for everybody?
So it's access for all in the right scenario, right? And Decadron gives you so many more variables about how we can give it. Obviously, we can't give Solumedrol through a nebulizer.
Right.
So you could give Decadron through a nebulizer. But it is important to remember that there is very little to no good data that says nebulized Decadron really works from an anti-inflammatory standpoint.
Yeah.
So it probably does. It's a steroid. We're absorbing some.
Right.
But there is really good data that Solumedrol works for that COPD patient. So if you have the choice, choose the better option. Choose the Solumedrol. Don't just go, look, I can just put it in there. I don't have to worry about it.
Right.
But if you also have a really long transport, you can't get an IV, you've tried multiple times, maybe Decadron is a good option.
Yeah. Always love options. So moving on, and this is another one that I am super excited about. Ketamine for seizure management. I know you and I have talked about this extensively, but I am like super excited to have ketamine as a backup, right? So talk to me a little bit about that. Why now? Why?
So I think there's
Research?
Finally some good data.
Yeah.
Yes. And so the early data that we're seeing coming out of Palm Beach, Florida, Peter Antevi, his organizations, they've been trying to use it and collect data to see. And some of their early studies showed really good results. Now, to be clear, I want to make sure everybody understands how we're using ketamine. This isn't our first line. We've used some benzodiazepine. We've used some Versed, and it hasn't worked. They're in status. This is another option that we can go to after the benzos are failing.
Okay.
But it's a true sedation dose.
Right.
It's the big dose, right? We're going to put them to sleep on it. But Palm Beach saw really good results. In fact, their first 25 or 26 person study, they had 100% clinical resolution. Now, we don't know if they're still having some seizure activity, but they were no longer shaking, all of those kind of things. And so I think the data is enough that we know we're not going to cause harm, and we potentially can abate some of these status epilepticus patients that we couldn't before.
Yeah. So I know in my own practice, I have had patients where I've had to intubate them and RSI them because it's gone to that point where I've given them just so much benzo that it's just not working, and so then I had to put them down and continue to give them the benzo. In those instances, I probably ketamine could have worked, and even if it didn't, now I've got my pre-medication, right? And I can go right into RSI if I needed to.
Right.
And do I need to still give that benzo? Like we've been telling people to, like after we've RSI'd them with that ketamine?
Well, ketamine, it has a short half-life too. I
Right.
mean, you may have to redose ketamine or you can use the benzo. I think my favorite question that I want to make sure people understand is how much benzos is too much in a seizure patient. And there is not an amount that's too much. It is too much when you give them so many benzos that they quit breathing, and then you just need to address the breathing, but then give them more benzos.
Right.
The other is if they get hypotensive, that will cause some hypotension with it. And so I think the ketamine gives us a benefit in both of those. So we want to continue to load them. And the reason why you had to intubate somebody is because you knew you were going to continue to give benzo after benzo after benzo to try to control it. That's okay. But ketamine gives us another option. I'm going to give this. Now, and we know they're less likely to lose their airway or quit breathing if we give them ketamine versus the benzo, right? So I think it makes it a little safer, but not without its risk, because you've already loaded them with benzo. So now we're crossing two different sedation medicines. So they are likely to lose their airway if we use a lot, but they were guaranteed to lose their airway if we just had to keep escalating our benzos anyway.
So at what point do I switch over to ketamine? Like, is there like a magic number? Like I give 10 milligrams, 20 milligrams, 15?
I think after a couple doses of failed benzos and they continue to seizures, I would go to the ketamine very quickly.
Okay.
I would not be... Now, do I want you to give 10 doses of benzos? No, I'd like you to start that early.
Right.
But do I want you to give one partial dose of benzo and then go to ketamine? No. The data really shows that benzos are our best first line.
Right.
And we really need to fail it. So don't give that guy 2 milligrams of Versed and then go, here's your ketamine.
Right.
I'm going to really stop your seizure. Let's really give them an adequate dose of benzos. If you feel like you've given them a really adequate dose, then go to the ketamine.
All right. Speaking on ketamine, on the flip side of that, we've got Zyprexa, right? Coming in, and it's going to be the oral Zyprexa for those mildly agitated patients that you can kind of like verbally talk to, but they're not like fighting you.
Yeah, this is just another tool in our toolbox that I'm super excited about that we'll be able to use. It is the oral dissolving tablet, like the Zofran that dissolves, but it is the Haldol dissolvable tablet.
Yeah.
So we can use Zyprexa and it works about as quickly as Haldol. It's not super fast. We're still going to wait that 10 to 15 minutes like we do with Haldol for them to kind of slow down. But that oral dissolving tablet for that person that you can talk into taking something. No fingers in somebody else's mouth. We're not putting it in somebody's mouth. But that person that's agreeable, like, hey, I can give you this medicine. It'll help kind of calm things down. They can put it in their hand. They take it. If they throw it over their shoulder, all right, now we know they're not going to be as compliant. If we lose a Zyprexa on the street curb, that's fine. But a good option for us to try with that patient.
Yeah.
No, and just like with Haldol, somebody that has overdosed on their own antipsychotic or taken a whole bunch of Haldol before we got there, maybe this antipsychotic is not the best option to give them more Haldol or give them more Zyprexa and cause that QT prolongation and those kind of things. But there are definitely patients that we're going to benefit from this.
I think so. I think that there will be lots of patients that could probably benefit from it. So another one that I am super excited about, IV Tylenol.
Yeah.
Man, long time coming.
Yeah. You're not going to try to say it? The name?
No.
Ofirmev,
No.
I think. Yeah, so, and if you look up IV Tylenol, obviously Tylenol's a trade name. It's not going to come up.
Right.
You can look up IV acetaminophen. Ofirmev started out over hundreds of dollars a dose when it first came out. It really limited its use. It's come down a few years ago. It was down to the $60 to $80 a dose. When you figure our narcotics and pain medicine are pennies a dose, it just didn't make good sense. But now with it being $6 or less a dose, it's still astronomically higher than some of our narcotic pain medicines, but still a very reasonable dose for somebody that we don't want to give opiates to, or we want to try to give them a different alternative. And the data looks really good.
Yeah. So we can use it for pain management. So are these the patients that are like the chronic pain patients that we kind of typically have, like the chronic back pain, that maybe it was a trauma recently that maybe they fell, and because we don't have the same problems that we might have with bleeding with like Toradol, right?
Right. So I think it should be a really good trade for Toradol in most cases. That person that is the classic kidney stone, Toradol is still the best answer. That's really helps. But this IV acetaminophen is huge. People report pain relief levels equal to some narcotics, definitely equal to Toradol, except for maybe kidney stones. So I think our scope should potentially be really wide. I think there is a couple things we got to remember, though. Its onset time is going to be slower.
Yeah.
So IV Tylenol is probably not the best drug for that femur fracture that you want to try to make comfortable in the next 5 minutes. Mm-hmm. It may take a little longer for that to set up. But even though it takes a little longer to set up, it's also a great option for lots of people that have chronic pain, or we've failed with, they're still pretty miserable with narcotics that we've used, or just all kinds of options. And we can use it for fevers at the same time. So once you have the IV, for some of these patients that are either intubated and febrile and they're tachycardic, or they're just miserable from their flu, all those kind of things are things that we can use this IV Tylenol or IV acetaminophen for.
All right. So speaking of fever, so my septic patient, could they potentially get both Rocephin and Tylenol?
Absolutely. So that can help bring down their temperature. And, we treat a lot of tachycardia that is likely with a whole bunch of IV fluids that may be just from the tachycardia of their fever. And particularly our longer transports, this gives us a chance that we're given IV fluids and given the IV acetaminophen or a Firmriv, however you want to say it, and their heart rate comes down before we get there. We'll know we made a difference. Will we know which one? Maybe not, but it just gives us another tool that I think is going to be super useful.
All right. So I lost my spot.
That's all right. While you're looking in here, I'm going to silence my phone. Sorry.
You're good. IM Epi for neonatal. Can we talk about that?
Yeah, we have not. But that is one that has a whole lot less information or studies behind it. So that neonatal epinephrine in cardiac arrest. The reason we went to that is there's not a lot of science behind it. There's one trial out there of intramuscular epinephrine in a neonate. We don't know if it works that well, but we do know there is a fair amount of science that knows that epinephrine down the ET tube doesn't work.
Right.
We absorb very little. It doesn't make much of a difference. But that was still in our protocols because if you couldn't get an IV, you weren't at the level where you're getting an umbilical line, we just didn't really have an option. So we were pushing epinephrine down an ET tube that may or may not, a neonate that may or may not be even intubated at that time, when we should be focused on bagging or neoteing that patient. And what do we do about the epi? So this IM epi just gives us an alternative. Not great science behind it. I'll be the first to say this is a little bit sketch of all the protocols that we have, but we know there is good benefit from IM peds for anaphylaxis. There is good absorption when we use epinephrine in small pediatric patients for blood pressure and anaphylaxis and things that are responsive to epinephrine. So our hope is this gives us another alternative to get epi on board for that neonate to give it a chance.
So are we still doing like the max 6, max 3? Is there a...
Yeah.
I can't imagine that I'm going to poke a kid.
I think
six times.
if you're not getting somewhere in that resuscitation in the first couple, you're not going to get somewhere, right?
Right.
And so this is. I wish I could answer for sure where that number is.
Right.
We don't know where that number is on adults,
Right.
let alone neonates. And if you know the science or the lack of science behind our IM epi here now, you can get a dose or a couple doses of epi on board on a neonate if you decide to transport them, or if you're going to work this code in a neonate for a little bit. We know we have some epi on board. How much? We don't know. They have low volume mass in their thighs, so we don't know how much they're actually going to absorb, but I know they're not absorbing it out of their ET tube.
Right.
Particularly if they don't even have an ET tube, when we're just ventilating them with our new NeoTs.
All right. Let's move on. Let's talk about labetalol in the pregnancy.
Yeah. So labetalol is a huge step for us. We know that when we typically call, we don't get the approval, the medical control approval to use labetalol, but it is very black and white that we know in pregnancy, when you have preeclampsia, you should be getting labetalol. And for you to sit on the phone for 5 or 10 minutes, 15, 20, ridiculous amounts of time to ask an ER doc about labetalol for a drug that we know absolutely they should be getting, then that medical control has come off for those preeclampsia patients. And these are young, healthy patients.
Yeah.
And we're usually pretty aggressive about the labetalol, giving them labetalol quickly, frequently when they have those high blood pressures.
So what about it being added for the persistent VTAC too?
Yeah, so there, again, that's just another tool in our toolbox, right? We have lots of things set up for that persistent VTAC person. You shock them a couple times, they're still in VTAC, they won't come out of it. We can use lidocaine or amiodarone. That doesn't work. We have in our protocol about dual sequential defibrillation or changing the vectors, moving the pads, shocking them again, seeing if we can make a difference. Well, there is some science behind if we can slow their rate with labetalol, we have a better success rate at defibrillation. So again, I don't think we're going to harm anybody in this situation. You are in persistent VTAC and you are not going to survive this if we don't change your rhythm.
Right.
So again, no reason for you to be waiting on the phone for 10 minutes to give them the drug you know that might give them a chance.
All right. What about adenosine? Changing the what is it, the dose, the repeat dose without a repeat dose?
Yes.
12 milligrams, just going straight to 12 and that's it?
Yeah, so more and more electrophysiologists, the cardiologists that do this on a regular basis, they do not waste their time on 6 milligrams. If they're going to get it, they want this to abate somebody's rhythm. And so they're going after it with 12 milligrams, giving them a big dose like that. But if you don't convert them, then also, because we don't have all the diagnostic things I have in the emergency department, if that didn't change it, we want people kind of evaluating, not just redosing with another 12 or things like that, reevaluating, is this really SVT or is this a flutter with a fast rate? Is this sinus tach with a super fast rate? It gives us a chance to reevaluate that.
And speaking of electricity, when we go there, what is that? We don't incrementally go up anymore?
Yep, give it all.
Give it all.
Right? If we're going to go to this point, we're going to our max defibrillation and cardioversion dosing. It's what all of the electrophysiologists do. They've been doing this for the last 25 years. They're like, why would I start at 160 when I know my success rate is significantly less? I'm going for the high number and I want to shock them one time. Not, I'm going to shock you 3 or 4 times. And so there's no reason for us to escalate. There's good science behind why we shouldn't escalate. And It's what all of the professionals in the world of cardiology do.
So start at 200, and if that doesn't work, do another 200?
Yes, we'll stay at that max rate, and then you don't have to worry about escalating
Right.
doses and setting it up. So
All right.
we'll just go after it.
Makes
Give it
it
all.
so much easier.
Yep. I have more than a handful of cardiologists. If you're going to shock them, give it all.
Yeah.
All say the same.
All right. So there are several DNR related changes as well. What kind of prompted some of those DNR changes?
They were mostly case studies or things that we've had. And some of the DNR things, we really wanted us to have the control that we should. If somebody has DNR paperwork, there's no reason for you to have to wait for ALS or make a phone call in. I mean, if they have the official paperwork, that's appropriate for you to make that decision about, I'm not going to resuscitate this patient, no matter what your level in EMS is. And so I think that's, we're just kind of catching up with cleaning up language we've had in our protocols.
So along that, so let's just give you an example. So I am working a code. There's no DNR paperwork as of yet. So we started the code, we worked it, and then the family is able to produce that. Do I need to call med control?
No, not at all.
I can just be like,
Yep,
okay, I
that
looked
is
at it and
completely
boom.
appropriate.
Okay.
Ethically, we all want you to stop, right?
Right.
The family wants you to stop. I want you to stop. You want to stop. And before, just the wording of our protocols had limited you to call for that because you'd already started it. Once you see that paperwork, we know what they want.
Yep.
It's been documented. It's official for the state of Missouri or Oklahoma or wherever you are.
And it doesn't have to be the original, right? It can be a
Correct.
copy.
Correct. If you think it's legit. Now, obviously, we always want you to have clinical decision making of, man, this doesn't seem right. But, 99.9% of the time, you're like, this is all official. This is what it is. This is what the patient wants. This is what the family wants. You should have the power to make that call. And the states give you that power. We had just kind of limited you through the wording of our protocol in the past.
All right. All right, so let's do a rapid fire round. Let's do a myth or fact. So, every fever needs treatment.
Absolutely not. Myth.
Okay.
So that's our body's mechanism to fight infection. So a little bit of a fever is not a bad thing. It's just a bad thing when we become so miserable, or it makes us not want to eat and drink, not want us to get out of bed and move around, all those kind of things. So not every fever needs to be addressed. Now, there is a number. Once you get over about 104.7, some people say 105.3, whatever it is, whatever that exact number that starts to damage cells, those need to be addressed.
Okay.
But that 101.5 that doesn't care that they're 105, that doesn't need to be addressed. Doesn't have to be.
Let the body do its natural thing, right? All right, next one. More epinephrine is always better during an arrest.
It is more better when you want to have to transport somebody, or more better if you want to stay on scene and work it a long time. The science may tell us in the next couple of years exactly what we need, or maybe the next 4 or 5 years of how much is too much and when, but more is not better. The majority of people after about 3 or 4, if they're not responding to that, are not going to respond. They may get some escape beats, or maybe even get a little bit of some cardiac activity back, but those people are not surviving. So more just means more work.
All right. Every agitated patient needs ketamine.
Definitely not. Myth.
Okay.
Not every agitated. And I may not be that guy, but we have all worked with the drunk whisperer.
Yeah.
The person that can get that person to cool down and take maybe a Zyprexa, or take a little bit of Ativan, or not Ativan, but Versed for us, a little bit by IV or things like that to chill out a little bit.
Yeah.
So definitely not every agitated person needs ketamine.
All right. End title is only used for intubated patients. Only useful.
Oh, myth. And Eric Howard is setting up right now, clutching his chest.
I know,
Levine's, right? And definitely myth. No, we have so many more uses for this. Any acidosis that you want. So somebody that's alcoholic acidosis, their CO2 is going to be lower. A septic patient, helping us determine how well they're ventilating, whether they're a COPD or a CHF or any of those things, not just for that one case. We can use this in so many different avenues.
All right. So let's as we come to a close, why don't you tell me which protocols you're most excited about out of these?
I'm pretty excited about the Zyprexa. It has gotten cheap enough, and it's a good alternative for us to use. It just gives us another alternative so that we are not jumping on top of somebody and it's like, hey, I've got you kind of tucked down, but let me hold you down and give you this extra shot too, just to make sure you chill out for our ride. And so I'm really excited about that use. I'm excited about seeing how things will develop with ketamine, how successful it will be for us in the second line for seizures, for sure.
Yeah.
How about you? What's your excitement?
I think ketamine. I've been on you for the ketamine for a while on seizures, and then the IV Tylenol. I'm pretty excited about that too.
That is pretty exciting. I think one of the things we haven't talked about, so there is some limited studies that show IV Tylenol in a super sick person. Mm-hmm. So it was all ICU patients, did have a much higher incidence of hypotension after we gave it. So IV Tylenol may not be the best option for that super sick patient.
Okay.
It may be for all the other patients we see.
All right. What are your big takeaways from these protocol changes?
My biggest is that people are invested in taking care of our patients, because all of this is driven from you and all the other paramedics you work beside, all the EMTs you work beside about, hey, what do you think about this? So my biggest takeaway is just being excited that I'm part of a program that people are just like, I'm just coming to work. I don't care about what I do, why I do it. I'm just coming in for my paycheck. I'm going to get through my job and go home. I'm excited that we're part of an organization that people are like, I want this. I want this because I can take better care of people.
All right. And last question, probably, maybe. So looking ahead, what areas do you see kind of moving towards either getting rid of or adding to, or, our practice in the future?
I think the development of more critical care is definitely our future. And you will see in these protocols a P3 or a paramedic 3 level that we haven't figured out all of the training requirements and requirements to get there, but you can see it's already starting to show up in our protocol, so it's ready for when we are ready to use it. And so I see changes of more and more critical care that I'm super excited about.
All right. What about C-collars? Are we getting rid of C-collars?
Oh, man. I don't know. That. I can tell you definitely there's not good science with that. There's horrible science of why we put it on, but there's also horrible science saying it's safe to take it off or not use
You
that.
knew I had to throw it in there.
I love it. No. And that was a question that we got a lot about, and we really looked into it, but there's just not good science saying that we're ready to get rid of them yet.
All right. That's fair enough, I guess. So, all right. Well, thank you for taking the time just to come out and talk to us about it. I know that we've got lots of changes in this new protocol. So I thank you for that, and excited to kind of see where it goes.
Yeah.
So any closing thoughts?
No, I appreciate you taking the time so that we could kind of have a conversation about it so people could listen. And hopefully this stirs more questions than answers for you guys so that you can continue to ask Josh or me or Eric about why is this and how do I use it more appropriately this way, and as you get the education on our new protocols.
All right.
Not protocols.
Guidelines.
Clinical operating guidelines.
There you go.
That's what I love.
Yeah. So, all right. Well, thank you.
Thanks.